We'll move on to the next session, which is a panel discussion on high-risk ALL. It's my pleasure to welcome Dr. Revati Raj as the moderator for this panel discussion. Revati ma'am is the consultant in Apollo Hospitals, Chennai. Her areas of interest include hematopoietic stem cell transplant for thalassemia, PID, childhood leukemias, and novel therapies like cord blood and haploidentical HSCT. We have with us the panelists for today. Dr. Sirisha Rani, she's the consultant pediatric hemato-oncologist at Rainbow Children's Hospital, Hyderabad. Dr. Manas Kalra, senior consultant at Sir Gangaram Hospital, Delhi. Dr. Vandana Bharadwaj, associate professor pediatric hemato-oncology at St. John's Hospital, Bangalore. And Dr. Prashant, a consultant pediatric hematologist and transplant physician at Wadia Children's Hospital. Welcome all of you to the panel discussion.
So thank you, Vasudha, and I want to congratulate all of your team at Rainbow Children's Hospital and wish you all the very best to help lots and lots of children with cancer, and hopefully the years to come without the pandemic, it'll be good. But you've started off with a bang and sharing knowledge in this platform, which is really a good way to start your unit. So all the very best from all of us. And all of the four panelists are amazingly great physicians and good friends. So you've introduced them already. So I'll just set the background to say that worldwide, we are seeing great improvements in outcomes in ALL. But what about our country? We know that we have to do good risk stratification and see how they do on day 28 and look at long-term survivors, reduce therapy-related morbidity and late side effects. So there's a lot of things to balance in ALL. So I just thought for a couple of minutes, I would share the data from our center, which we looked at recently, because 2009, we had MRD available. So with risk stratification, when we had a cohort of high risk, what did we do? What impact did it have on the outcomes? So we had put in kids on regimen A or regimen B as per the UK ALL based protocol, and based on the MRD, decided whether they have to move up to regimen C or continue on regimen A or regimen B based on MRD. And initially we had 0.01% of as our cutoff, and over the last couple of years moved to 0.005. And we looked at total 287 kids with at least the 2-year follow-up from up until Jan 2021. And out of these, we had good risk cytogenetics in roughly about 45%, which is what Mayur had said, that about 45–50% of our kids will come under the good risk cytogenetics. So these are the kids that we don't have to worry about, are we placing them in the high risk group or not. But high risk and intermediate or negative cytogenetics, we have a significant number. And when we've started them on chemotherapy as per regimen A, which is a 3-drug induction schedule, or regimen B, which is a 4-drug induction schedule, about a third of these children went on to the high-risk regimen, which is regimen C, 74 children. And you can see clearly that out of 148 in regimen A, 23 were MRD positive, but out of 136 in regimen B, a significantly higher number, 51 were MRD positive. So when they've continued on regimen A throughout, this is the problem, that when we think they're low risk, a lot of them had relapse. But when we had escalated them from regimen A to regimen C, the relapse rates were lower. And the same with regimen B, when we've continued, our relapse rates were higher, but when we've escalated, it wasn't so bad. So, and the relapse timing, a lot of them were in that 6 to 18 months group. So 23% of our kids relapse. So what are we doing with our risk stratification? MRD alone is not enough. And the majority of the cause of death was relapse. So infection or transplant-related mortality was not so high, but we lost kids to relapse. And our disease-free survival, when we do long-term data, we're looking at about 67 to 70%, which is much lower compared to what we could see in from Western data. So what is the way forward? We need to identify high-risk children. We need better tools. We need targeted therapy where possible. And we need to avoid unnecessary transplant, which adds to their morbidity and mortality. So with this brief introduction, I would start the panel discussion and invite Manas to give us his thoughts on how do we actually say who is high risk in our country, given the limited resources for risk stratification.
Thank you, ma'am, for the nice introduction that you have given. And, thank you for sharing the data of your unit, which is, actually quite nice, because from developing countries, we don't have as much data to substantiate the outcomes, the real world outcomes of acute lymphoblastic leukemia. So when we have to basically risk stratify children with acute lymphoblastic leukemia, we use some of the common simple parameters are uniformly used. And I think I would really highlight the importance of prednisolone poor response. And if you are a prednisolone poor responder, then you are most likely going to do poorly as compared to other children. So that is something that we get very early on when we start managing acute lymphoblastic leukemia. The other thing is CNS positivity. So if you are CNS positive, again, you are probably classified as a high risk acute lymphoblastic leukemia. Then we look at the cytogenetics aspect, and Mayur had very nicely elaborated on that. And we all know that MLL gene rearrangement, Philadelphia chromosome positivity, hypodiploidy. These are some of the things that we identify in our cytogenetics, and that also leads to classification to a high risk ALL. Also important is the status of the bone marrow at the end of induction and the MRD. Along with that, newer parameters like IKZF, intrachromosomal amplification 21. These are some of the newer things which have come up and which have, kind of increased our understanding of why some children who apparently look like standard risk or intermediate risk have relapsed despite good chemotherapy. So, as the time is increasing, we are actually seeing more and more parameters which are helping us classify an acute lymphoblastic leukemia into a high risk or a standard risk or an intermediate risk category. When we talk about T-cell ALL, ETP ALL is generally thought to be, some who would, do poorly. And a white cell count of more than 1 lakh is generally considered as one of the criteria where, you will probably have trouble and there are high chances of relapse. But I would like to highlight that all these risk stratification parameters have to be looked into the context of the protocol that you are using. Have a protocol for your center, stick to the protocol, have your risk stratification for your center, and then utilize that to kind of allocate the treatment arm that you have chosen for that particular risk stratification. So in general, these are the parameters, and one would use the parameter based on the protocol that is being used at that particular center.
So thanks, Manas. I think it's absolutely essential we identify these high-risk children, because if we are treating everyone on the same protocol, we're going to be over-treating a lot, and we'll have therapy-related morbidity, mortality, and we can't afford to over-treat all our children. And under-treating means that we will have the second highest diagnosis that we have in our country, which would be relapsed ALL, because we're not optimally treating them upfront. So it is a very valid, but MRD is essentially the backbone. And in this day and age, none of us can do therapy for ALL without MRD-based risk stratification. And I'm so glad that the ICICL protocol has MRD as the backbone. And the only, as you rightly said, timing of MRD is important. And in BALL at the end of induction, and in TALL, you could give them a bit more time and do at the end of consolidation to do your risk stratification. So this is for Sirisha. If you had a girl child with ALL who had a stormy induction, all barn door standard risk features, girl less than 10 years, low white count, hyperdiploid. But the induction was very stormy, lots of sepsis, and we could only give 50% of the doses we wanted to give because she was too ill and she was in the ICU, and she's MRD positive. So how would you treat this child? Would you escalate her to the high risk protocol, or you would say based on the initial parameters? These are practical issues that we face every day with our risk stratification.
So, good afternoon, all. Thank you, Vasudha, for invitation, and thank you, Revati ma'am, for setting a platform with by sharing your data. So, as you already said, like this is a standard risk ALL child, girl, 3 years, WBC count standard, and hyperdiploidy. So, before going into the case, just looking at the literature, right from international data, right from 1990s as well as 2000s, they clearly state that despite having underlying good risk factors like tele-AML or hyperdiploidy, MRD is the independent risk factor to say that it is in predicting the relapse. So, and that is also supported by recent data published by St. Jude Group in 2017 in Leukemia Journal, where they have seen more than 450 children, stating that hyperdiploidy of more than 50, chromosome number of more than 50 with MRD negative, relapse rate is very less, almost to the tune of 1.5 to 3%, tele-AML versus hyperdiploidy. Whereas good risk genetics with MRD positivity, relapse rate is higher, but compared to population where MRD is positive but no underlying good risk factors, it is better. So going by that, still even recent publications also states that if you have underlying good risk factors, the relapse rate is less but definitely higher than MRD being negative. So MRD is still an independent risk factor in predicting the relapse rate, which has already been demonstrated by data Dr. Revati has just projected. So coming back to the case, this case definitely received only 50% of the induction drugs because of, unfortunately, because of the stormy course. So here I don't want to put the child under high risk. So even this also comes under GPR, though because going by the count. So everything is standard. So going by that, I don't want to put this child under high risk. Good consolidation doses along with good supportive care based on the induction, cultures, and radiology and other problems that happened in the induction. With that, I will go ahead and give good consolidation and repeat the MRD and make look at like what is the percentage to make sure that it is less than 0.01 before I escalate the treatment for this child.
Thank you, Sirisha. Anyone else have any other thoughts on how they would deal with this child? Because there are two seminal papers, one on what was the outcome for children who couldn't have PEG asparaginase. Maybe they had anaphylaxis or they had a thrombosis and we couldn't go back and give the second dose of PEG asparaginase, and what happened to the children who had steroid exposure. And both of these, because this child will basically be someone who has had like steroid exposure type and then come to you for treatment, and both of them seem to have poor outcomes. So in our center, we would consider put them on the high risk protocol and consolidate them rather than go ahead with the standard risk. I mean, this is again, there are no clear guidelines, but again, when we look back at data, 19 of the 402 kids who had presented to us with ALL had just as data sharing, had steroid exposure prior as SOJIA or as ITP. And invariably, all of them have relapsed. I think we have only 3 of them who are recent patients, but 16 out of these 19 have had a relapse. So the outcome for these children, if we put them in the high risk schedule, would be better. Is these are just my thoughts. Maybe Ajay Vora, when he does his talk, could answer such questions. So
I also like to say that, you know, this child had a very stormy course
Yeah.
during So, that also will probably play in deciding how aggressive you can go in consolidation, because if the general condition is really poor, maybe we'll not be able to escalate as much. So I think, we'll have to take the conscious decision with keeping
Yes,
the
ma'am, that is
MRD
what.
and
Absolutely, absolutely. That's what I
Yeah.
said. This is a practical everyday problem. So there's based on the individual, and that's what they're doing in Western centers when they've had a stormy course. Give them a break with 2 Blin-Cyto cycles, because then it gives the body some time to recover. But most of our patients wouldn't be able to afford the blinatumomab. So for Vandana, what are the indications for screening for PH like ALL in our country, and how would this alter your management?
Thank you, Revati. For the juniors in the group, so PH like ALL, it comes under the category of B other ALL, and it's about 10 to 20% of children and 25 to 30% adults from international literature. These are usually the children that have a high white cell count at diagnosis or are MRD positive after induction, like our case just discussed. There is little consensus, though, in international literature about when and how we should screen, and the optimal screening method as well as timing are moving targets. But so far, there has been some strategies, and the COG group have used FISH as well as low density microarray for ABL, JAK-STAT, EPOR, and CRLF2 to come up with an algorithm. Next slide, please. This is the COG algorithm, and I won't go into too much detail. I know Dr. Mayur went into some detail about diagnosing B other ALL this morning. Next slide, please. The Chandigarh group have published this data on screening a practical and cost-effective approach to B other ALL in India, and this gives some details about how to use the cost-effective screening. So using CRLF2 by PCR or flow cytometry as the first step, and then using MLPA to identify Icaros, the EBF1 and PAX5 deletions, and then using multiplex PCR to get the JAK and the ABL group deletions. Next slide, please. Why should we do this? And this is because there are targeted therapies available. So a tyrosine kinase inhibitor can be used for the ABL1 and the PDGFR mutation groups. And the JAK inhibitors, ruxolitinib, which we use in many other areas like myeloproliferative neoplasms as well as for GBH, can be used in this setting, but this is not proven yet, still experimental. And the postulated theory is that higher doses as compared to what we use now need to be used. Some other non-targeted therapy implications may be using vincristine and steroid pulses during maintenance, and using high hematopoietic stem cell transplant for the MRD positive patients in this particular category. Thank you.
You're absolutely right. The talk by Mayur highlighted to us for clinicians. I think when we see a lot of lab data, we sort of freeze, and I usually call this pati patni or woo, this be other, and we only look at it at the end of induction. And if we risk stratify at the end of induction, if they are MRD positive, there was one interesting question at the end of his talk. Some of us outsource our MRD, and by the time it comes back, it's positive. How can we go back and do a marrow? Always make it a point to do DNA storage on your day 0 and day 28 bone marrow for the leukemic, so that if you want to go back and look at it, then you at least have the DNA and you don't have to go and repeat the marrow. So most of us have DNA extraction and storage facilities because we do this routinely for genetic counseling. So it's good practice. So Prakash, how do you place the NGS?
Prashant Revati.
Oh, I'm so sorry. Prashant. Okay, sorry. So how would you place the role of NGS in ALL risk stratification? Yeah.
I think the role of NGS in leukemia is still evolving. I think Vandana answered a lot of those questions. So ABL class fusions is one category of ALL that we need to understand or know. Especially if the child is not responding to conventional chemotherapy, because TKI inhibitors work well in this group of patients. But when to do when to do the testing at the outset, or when we see MRD positive results at the end of induction. It's still an open question. I think as we move forward, we will be doing all these tests upfront at diagnosis itself. Of course, cost would be an issue in India.
If we do one NGS, they give you a printout with so many that are positive. So is it really worth going through this? And, how do we counsel families? Because when we get the data, at the moment, we're not where we can offer any change in treatment based on that. Sorry, we can't hear you. Prashant, we're not able to hear you. Shall I move to the next question and then come back? So Manas, if you have a TALL kid who's MRD positive, what are the options available in India at the end of consolidation?
So ma'am, we know that TALL is a bad disease, more aggressive as compared to the BALL. TALL usually takes longer for it to become MRD negative. We are aware of this fact. So if you have a TALL which is positive after induction but not very high, we wait up until consolidation to see how things are. And then if at the end of the consolidation also, if the MRD is positive, this patient probably goes towards the direction of a stem cell transplant. The options that can be explored are, there is a role coming up of a drug called nilarabine, and nilarabine has been used mainly in the American centers, but also in UK. But I think in the US centers for TALL, they have kind of started using nilarabine for most of their acute lymphoblastic leukemia, especially for the intermediate and the high-risk patients. So that is something, but if you look at the data of nilarabine, the issue is the benefit that you gain by adding that drug. It's not very huge. It is definitely there, but the percentage is not a lot. So that is something that we need to think about, whether that can help. We are actually adding it immediately after the induction for patients and giving it as a 5-day infusion. Now, the other drugs that can be used and have been tried are bortezomib. It is a proteasome inhibitor. It's available. It's not very expensive. And that's something, especially for the relapsed leukemias, bortezomib has been tried. I think there is a role. We are not very sure where exactly we have to fit in.
I think drugs there's a lot of data coming on venetoclax and bortezomib in TALL.
Yeah. Venetoclax is the next drug, which is again coming up in TALL. So probably some of these drugs we need to identify. Daratumumab is again not available to us, expensive. These are some of the agents, and TALL being TALL, we probably have to watch out this space and see how these drugs can fit into our protocols and improve the outcomes.
So Sirisha, thanks Manas. What is the data available in your center? Do you use Capizzi or high-dose methotrexate for these high-risk children? Which is better?
So, ma'am, as we all know, like Capizzi, escalating Capizzi with pegaspargine combination or high-dose methotrexate is mainly for CNS-directed therapy. So, in our center, we use BFM protocol. We use high-dose methotrexate, not escalating Capizzi. If you look at the data, international data clearly says, like especially by COG group, when they randomized Capizzi escalating versus high-dose methotrexate in BALLs, data, what they published some time ago in 2011, showed that high-dose methotrexate is clearly superior to escalating Capizzi in preventing CNS relapse as well as improving overall survival rates. However, the same group, when they published their data on TALLs in CNS3 cases in 2018, they did not see any difference between escalating Capizzi versus high-dose methotrexate. They proposed intensification of intrathecals as well as the introduction of early cranial RT in T-cell ALLs, especially in CNS3 positive cases. However, going back to our experience, we use high-dose methotrexate with levels measurement. So we measure the drug, we do drug monitoring, level monitoring. So going by that, we don't face whether we give 2 gram for B-cell ALL or whether we give 5 gram for T-cell ALL, we did not face huge difference in the toxicity. However, in 5 gram, we did notice that there is a transient reversible biochemical renal toxicity was a bit more compared to B-cell where we gave 2 gram. So that is one difference what we have seen. And there is also Indian data which is interesting, like published in 2020 by Delhi group, Dr. Jagdish Chandra et al. They have published, and then they compared only toxicity of Capiz versus high-dose methotrexate, because that is more important in Indian context. We are worried about toxicity. So they did not notice any significant difference in the toxicity profile, except that in high dose it is skin toxicity and renal toxicity is more. So that was interesting. And we also know the publications by Dr. Deepak Bansal and all. Without monitoring, we can give extended hydration and leucovorin rescue, and monitoring, clinical monitoring and biochemical monitoring will help in giving high dose methotrexate even in Indian context.
Thanks. I mean, absolutely. How we have to adapt doing high dose chemotherapy in our country in itself is a challenge. All these fancy drugs are now available, Vandana. So what are the indications if we have to choose a few for our kids here?
Sure. Next slide, please. So I'd like to talk about inotuzumab first. So inotuzumab is an anti-CD22 monoclonal antibody, and it is conjugated with the cytotoxin calciumycin, similar to temtuzumab. And it was first used in the INNOVATE trial. This is the in adults. Rate was almost 74% compared to 31%. And then subsequently published the use of inotuzumab in a compassionate setting in 51 in which the CR rate was 67%, and it is effective also in infants. And it can be used as a bridge to stem cell transplant in relapsed refractory ALL. There is a subgroup analysis from the INNOVATE trial by the Japanese group showing that it is also useful in Asian patients. However, sinusoidal obstruction syndrome, that is VOD in old money, is a significant drawback. Coming to BLINA, it's a bispecific CD19 directed CD3 engager, BiTE. And the trial that looked at this was the Rialto trial, 60% CR after 2 cycles. And they found that it's better in low tumor burden, i.e. those patients that had MRD positive as opposed to morphological disease did much better and became MRD negative, and high rate of MRD negativity. It is better tolerated than INO. However, noting the cytokine release syndrome, the neurotoxicity, and the logistical and practical difficulty of continuous infusion for 3 weeks. Again, this is useful as a bridge to stem cell transplant to achieve MRD negativity, because we know that in ALL, being MRD negative prior to transplant significantly improves your outcome. Thank you.
Okay, thanks. So again, I apologize for the spelling mistake. So Prashant, are you back? Can you answer this data from India? Yeah, thanks.
Well, I'm not aware of data from India on TBI versus chemotherapy-based HSCT, but maybe there is in some abstract from some of the bigger centers that have been doing transplant for many years, like AIMS PGI or your center. But from the Western data, it's very clear that TBI etoposide is the regimen of choice, because that gives superior outcomes compared to chemotherapy-based transplant. So now in the West, everybody has moved to TBI etoposide-based conditioning in the setting of ALL.
So, yeah, thanks. So I think there is data from Dr. Satya Yadav's group where they've used Thiotepa Flu-Bu, and the results are equally good with Haplo. So I want to thank the entire team, all of the panelists for this discussion, especially at lunchtime, and end with these take-home messages also from all our panelists to say, as much as possible, we need to educate our primary physicians to avoid steroid exposure before they refer the kids to us. We need better supportive care during induction so that we can deliver the treatment so that we don't put them into the high risk group. We have to adapt to available risk stratification tools, use pegasparaginase now that we have all the generics as much as possible, because we are trying to use Western protocols, but without the pegylated asparaginase, and that is the backbone of our treatment. And where possible, if we add targeted therapy, that would be good to avoid a transplant. And we have to choose HSCT very wisely for our kids to avoid long-term morbidity and mortality. Thank you very much for the opportunity.